Thank you everyone who stayed with us this afternoon, and welcome to those joining us newly for our final session of the second day of our Research Incubator Online Symposium, recognizing, respecting, reimagining 50 years of learning from carers and shaping what comes next. My name is Lukas Hofstätter. I'm the Manager Research and Development at Carers New South Wales, and I'm pleased to facilitate today's session on supporting CALD and refugee carers. The broader theme of the day today was understanding the present, exploring current challenges, emerging issues, and opportunities to improve support for carers across research, policy, and practice. This final session today will focus specifically on the experiences of carers from culturally and linguistically diverse communities, including refugee carers. The discussion will explore the current state of research relating to culturally and linguistically diverse carers, the challenges they may experience when accessing support and services, and the policy and practice changes needed to better recognize and support carers from diverse communities. As we move through the discussion, please feel free to share your reflections, comments, and questions in the chat. If time permits, we will address audience questions toward the end of the session. We also recognize that some of the topics, as previously noted, some of the topics may be personal or emotionally challenging for the carers with us. And again, we recognize that if you hear something that causes you distress or you need to talk to someone, we have a wellbeing officer available online who you're welcome to contact. Further information about how to do so will be posted in the chat right now. Without any further ado, I will now welcome our panelists and speakers for this session, starting with Dr. Ash Chauhan. Ash is a registered physiotherapist, early career researcher, and fellow in patient safety and quality, with more than 13 years of experience working within the Australian healthcare system. His research focuses on health services, public health, and improving health outcomes for priority populations. Drawing on both his professional and lived experience as a migrant and a member of the LGBTQI+ community, Dr. Chauhan is passionate about promoting more inclusive and equitable healthcare systems. Welcome, Ash. Ash will present the work that he's been undertaking together with Professor Reema Harrison, our second guest here today, and they will have a bit of a division of labor between the presentation and the panel afterwards. Professor Reema Harrison is a translational health services researcher and leads the Healthcare Engagement and Equity Research team at the Australian Institute for Health Innovation. Her research focuses on improving healthcare quality, experiences, and outcomes through stronger stakeholder engagement and inclusive models of care. Working in partnership with health services across Australia and internationally, Reema has a particular interest in culturally and linguistically diverse communities and people with intellectual disabilities. Welcome, Reema. And our third guest today is Abner Poon. He's a social work academic in the School of Social Sciences at the UNSW Sydney, with professional experience in the mental health sector. His research focuses on mental health, social work practice, the impact of mental illness on families and carers, family interventions, and the experiences of children of parents living with mental illness. His work also explores migrant health and well-being, recovery approaches, and community mental health care. Welcome, Abner. We will begin with two presentations, one from Ash and one from Abner, followed by a panel discussion exploring key insights, reflections, and opportunities for future research, policy, and practice to better support carers from culturally and linguistically diverse communities. We will start with the presentation from Ash. Please take it away.
Thanks, Lukas. So just checking you can hear me okay. And I'm just going to share my slides now. Okay, so I think people can see my slides because I can see them over here on the screen. So thank you, Lukas and team at CARES New South Wales for inviting us to present some of our work in relation to supporting carers from culturally and linguistically diverse backgrounds to this session today. Before I begin, I would like to acknowledge the traditional custodians of the land on which Macquarie University is situated, the Wallumedegal people of the Darug Nation, those whose cultures and customs have nurtured and continue to nurture this land since Jim time, and also acknowledge the lands from people who are joining from various lands today. I also pay my respect to all the First Nations people joining us today and elders past and present. I would also like to acknowledge that the work that I'm presenting has been conducted with a team of researchers who have contributed to this research. So I would also like to acknowledge them as part of the research team. And this work was led by Professor Reema Harrison, who is here on the panel today. So I'm pretty sure most of the people would have seen the 2024 National Carer Survey results have been described or talked about yesterday and today in some presentations, and carers would have also seen this. But I just wanted to highlight a couple of few points that I thought were kind of like important and stood out to me. So building on the fact that about 1 million people in New South Wales are the carers supporting people through their various journeys, healthcare journeys. This national survey led by Carer Institute New South Wales was completed by over 10,000 people in 2024. And in this survey, 18% of respondents identified as being from culturally and linguistically diverse backgrounds, and about 10% said that they spoke a language other than English at home. So when we talked about culturally and linguistically diverse background, we often talk about people who are either born overseas, speak a language other than English at home, or have a parent born overseas, or practice cultural and religious practices or social practices that are different to the Australian mainstream practices. Within one of the finding from the survey that stood out to me was about the proportion of people who were from CALD backgrounds who identified themselves as very young carers, so who were less than or equal to 25 years of age. And 30% of them were from the CALD backgrounds or from culturally linguistically diverse backgrounds. And then this highlight the growing population, that growing older migrant population in Australia for whom the younger generation would be the caretaker. The other thing that stood out to me was particularly around the unmet needs. So as compared to the previous survey, which was conducted in 2022, there was a steep increase in the unmet needs of the carers. And most of these unmet needs were around emergency and planned respite, and also in relation to skills training. And I thought this was important because we will talk about skills training or building skills in managing care for the people from culturally and linguistically diverse backgrounds in our research today. So these are so before I go into our particular research, I just wanted to highlight some of the challenges for carers from culturally linguistically diverse backgrounds that have been highlighted in various fields. So one of the paper that I came across was from, I think, Abner Poon. So he would be talking about this in his research a little bit further. But what we know in the context of carers from culturally linguistically diverse more broadly, that they experience language barriers. So availability of interpreters or resources in non-English languages is sparse. Navigating health systems, especially complex and unfamiliar health system, is a challenge, especially for somebody who is a new migrant. And this was reflected in our Can Engage project as well, where carers identified that they had difficulty finding where the support services for them were in relation to managing some of the stress or psychological impact they had caring for their loved ones. The cultural expectations there is more nuanced cultural expectations in around family caregiving. So having the the structure of the family norms are slightly different to and so the cultural expectations around family caregiving is different, and also the cultural awareness and of the disease and wellness is a little bit different when we talk about people who are from culturally and linguistically diverse backgrounds, and it has impact on the carers from this background as well. Especially people who are new migrants, they are not very well connected to the social networks or community connections, and this may increase social isolation among them. Some other challenges, especially in relation to refugees, who are the mistrust of the institutions. So going through the trauma that they had to go through in relation to the migration processes, etc., that may have mistrust in health system, governments, and institute, and that may further impact on their health seeking or seeking support from the institutes. And there is also, reflecting back on the earlier results from the survey, that 30% of the carers were from culturally and linguistically diverse backgrounds who were less than 25 years of age. So younger carers are supporting older family members with limited English. So they are often asked to interpret or translate nuanced medical terminologies or social services terminologies, which they may not be able to do that meaningfully. And also they're also often asked to bridge two cultures in relation to the managing the expectations of the illness and wellness and merge them with what the westernized health systems look like. So they might have some additional challenges in relation to that as well. Now, when we talk about cancer, so caring for patients with cancer is critical, the role of carers, especially in caring for patients with cancer, because cancer is a disease that can result in rapid health deterioration over a short period of time. And during this, carers are often asked to monitor and manage variable symptoms and toxicities. For example, fever that can happen because of the chemotherapy, and taking account of that. The carers also perform a range of duties as informal caregivers. So they perform a range of clinical duties like managing medications, coordinating appointments, treatments, managing diet, lifestyle, etc. And this often informal caregivers' duties are not recognized as such. And carers also contribute towards patient-centered sustainable delivery of care, which may expose caregivers to challenges that are detrimental to their own mental health. And so the psychological health and well-being of the carers who are supporting people from culturally linguistically people with cancer generally have not been examined or has not been examined. So we conducted this research, which was a qualitative research to explore the role of caregivers they play in providing clinical care for loved ones for the cancer, and explore their views regarding what kind of supportive care needs they need and in what form the supportive care needs should be provided to them. So as a qualitative study, we interviewed audit focus groups with 20 participants, 11 spouses, so partners, 7 parents, 1 child, and 1 sibling. And recognizing that importance of that people who are from priority populations, such as people who are from culturally linguistically diverse backgrounds, they may face additional challenges when they are providing caregiving duties to somebody who has been diagnosed with cancer. So we purposely selected 10 people who were from culturally linguistically diverse backgrounds into this research. We also interviewed and did quality data collection from people who also lived in regional remote areas and parents of the children who had cancer. So recognizing them as a priority populations, we also targeted them to collect their feedback and collect their experiences to answer these 2 research questions. So what did we find? So we found 4 themes, interrelated themes. And the first theme was around dual burden of providing clinical care and managing personal emotional distress. So providing clinical care and consisted of range of activities that that the carers undertook as part of their informal caregiver duties. So, for example, this quote says that they they were giving medications, managing appointments, taking people to the hospital for their treatments, etc. Oftentimes, when the symptoms of the cancer became worse or the cancer progressed, this caregiving duties also progressed or also got higher or more expensive for the carers. And carers also said that they didn't know how to and where to gain support or the skills they needed to address these clinical care needs that were required of them. So like the causes that are, and often this resulted in increased psychological distress for them. For example, this quote says over here that I had my own family to look after, and top of that, not that I had to, but I wanted to be there for her and her family. So they were the biggest challenges for me. So managing burden in relation to supporting their own family, but also supporting the person who were they looking after as a friend or as a family member. The second theme was navigating healthcare partnership dynamics. So as there were differences in experiences. So for example, when the care process is very well supported, participants expressed that the experiences were good. So for example, this first quote which says that we are very lucky that we had a great support, especially from the hospital, from the doctors, and from the friends and neighbors. Very excellent neighbors. We had a lot of moral support from everyone, and that counts. But when the teams or care processes were fragmented, that put extra pressure on caregivers to take substantial care coordination and advocacy role. Especially for people from culturally and linguistically diverse backgrounds, carers said that they had to make sure that the religious considerations or cultural considerations were met within the care processes. For example, the second quote, which says over here, it was more just making sure that our religious requirements were met. It was more asking for a female nurse rather than a male nurse to tend to her, and little things like that. So they became the navigators in terms of making sure that the care assigned or the care processes were culturally, religiously aligned for people from CALD backgrounds who were affected by cancer. The third theme was developing a caregiving skill set. So as we discussed in the first theme, that when the cancer progressed, there was a rapid requirements for the carers to undertook increased clinical duties. And this rapid upskilling required at the outset throughout the course of caregiving to meet the task and the requirement of the responsibilities. And most of the times, carers felt like they were not prepared, or they had a very steep learning curve to understand how to carry and to perform these regular clinical tasks which were for them. Yes. So like the second quote which says over here, so very quickly we learned skills in note taking on a whiteboard. Whoever is in the room writes down the stuff that is happening. It's crazy how many times the nurses and doctors will just come in and look at our board. So it describes in terms of like how they undertook steep learning and learned as they go along in terms of how to manage the clinical care as an informal caregiver for somebody with cancer. And the fourth theme was unique supportive needs and barriers to access. So a range of stresses to manage with little or no psychological support readily accessible. Need to consider circumstance of caregivers in delivery of any support programs highlighted is important. And this was mainly in the context of how the support needs could be, or support programs could be made accessible to the carers. So, for example, the first quote says about, I wish someone had set me down and said, this is what the role is. I just had to kind of work it out by myself, but I wish someone had actually set me down and said. So this quote kind of highlights the need for the support system that prepares the carers in managing clinical duties as an informal caregivers, and also managing their own psychological well-being as well. And the second quote, which is about the flexibility of the program or the support, whichever is offered, flexibility considerations were important that they highlighted. So, what are the implications in relation to people from culturally linguistically diverse backgrounds as carers who are supporting somebody who had cancer? So, it is important to understand that the carers who are from culturally linguistically diverse background may have slightly different perspectives about their responsibilities as a caregiver, and that needs to be considered in a support program or that can address their psychological well-being as well. What we have seen that support programs have been often developed for patients that are being extended to carers, and co-designing a culturally tailored intervention or a support program with carers from culturally linguistically diverse background has come out as a very strong theme. For example, at COSAC, one of the cancer-specific conference last year, this came out as a very strong theme in relation to how do we progress further for supporting carers from diverse priority population groups, which includes carers from culturally linguistically diverse background as well, to support them and support their psychological well-being. The use of cognitive behavior therapy approaches to develop intervention tailored to the carers from CALD groups can be used in terms of informing the co-design and developing the support programs with them. One of the other things that in terms of the resources, multimedia resources for the support services available should be provided to the carers from CALD background. So having brochures, having videos, having other forms of media in terms of how to access support, what support is available, making those resources available in a different format, accessible format is important. And virtual care, use of virtual care to develop to targeted self-care and management, as the building upon that flexibility that has been identified in our research in terms of something that people can access at a time, which is suitable to them, which is readily available to them. So virtual care could be an important tool in doing that. So I'm just going to go to the next slide. So these are just the references, and I'm just going to unshare now. So thank you for presenting me. So thank you for having me here today. And I will unshare this. Thank you, Lukas. And I suppose we will have the questions towards the end.
Yes. So we will have sort of questions. If you have any questions, you can put them in the Q&A box, and we will discuss them as part of the panel after the second presentation, which is up next. From Abner, you could please take it away.
Thanks, Lukas. And of course, thank you, Ash, for your wonderful presentation. Fantastic to hear about your research. So I'm going to do a share screen. Okay. All right. Okay. Please let me know if you can't hear me or can't see my slide. So before I begin, I also want to acknowledge the traditional owners of this land, pay my respects to elders past and present and future as well. So my name is Abner Poon from the School of Social Sciences from University of New South Wales. I'm going to present this research on the well-being and recovery of families from multicultural communities. And this study was conducted by a few of us, Alex Lee, which you may have heard him yesterday, and of course, Ilan Kass from UNSW. And you can find this article from Australian Social Work. Okay, so before I begin, then I put out these questions for us to ponder about caregivers, carers, regarding their recovery. So in mental health space, we always talk about recovery of people with mental illness. So how does a family fit into this recovery process of people with mental illness? What are their roles in the recovery process? Can we just focus on the recovery of people with mental illness and kind of forget about the recovery of caregivers? And how well are carers recovering in current mental health context? And what else do we know about recovery of carers from multicultural communities? So overview of carers first. Again, I'm looking at the survey done by Carers New South Wales of 10,000 over participants. So there are a few key findings from the report. So these are some of them. So first is psychological distress went up from 47.7 in 2020 to more than 50% in 2024. And social isolation also went up from 56.2 to 61.2% in 2024. So I think these two areas really show the challenges that caregivers face. And out of the total sample, 2 in 5 carers, around 40% care for someone with mental health issues. And for those in contact with mental health services, more than 60% of carers said they were not asked about their own caregiving needs, their own challenges in mental health services. So when we look at caregivers, or even if we look at the studies of caregivers in mental health space, most of the studies look at challenges, look at needs, and look at a very problem-saturated approach. So a few of us look at how we can support carers' recovery. So the first one will be by Wider and Bland in 2014. They did a conceptual work and they published that. And they look at the making use of this charm recovery framework, how it can be applied to caregivers. Then they tested this framework in 2022. They published this paper. They found that the framework seems to be useful when they're working with training family peer workers, but they found that there is not really a linear process, and caregivers often face a lot of difficulties and distress. So therefore, they say it should be a charm D. So for charm, it means connectedness, where carers connect with other people. H for hope and optimism about future. Then carers develop their own identity, then develop own meaning in life, empowerment. So in 2024, together with Lukas and Sarah from Carers New South Wales, we published this paper making use of a large database, a survey that Carers New South Wales have done, a mixed methods approach, and we look for whether charm is being spoken by carers of people with mental health issues. So we look at all these areas. We found that yes, carers do talk about the charm, connectedness, hope, identity, meaning, empowerment, and so on. But we found that carers were talking about this last factor, which is not really mentioned in the literature, which is about recognition. So we think that recovery should be charm R. So now I'll go into this study that I did with Alex and with Ilan. So we look at caregivers of people with mental health issues. We want to find any family member or relative of a family member from a culturally linguistic diverse community, caring for someone with mental health issues and can converse in the English language. So because of funding issues, we couldn't conduct this study with people who don't speak English, so we are limited in that aspect. So we distributed flyers through a lot of caregiving-oriented organizations, for example, Carers New South Wales, Stride, Mental Health Carers New South Wales, and so on. And after that, we tried to interview people using a semi-structured interview, either online or face-to-face. And the interviews were done by me and also by Alex. We look at well-being, caring experience, recovery challenges, and perspective, how do we support carers? Then Alex and me, we did the analysis on our own. Then after that, we came together to discuss and we agreed on the themes. And the study is approved by UNSW. So these are the background of the participants. We interviewed 11 carers, 9 female, 2 male, age range 41 to 73, which is a typical age range of caregivers of people with mental illness. So 6 were born in Australia, 5 were born overseas. From those who were born overseas, 2 from China, 3 from India. I think these places where they were born speaks of something, because we try to interview people who are from culturally linguistic diverse communities, but 6 of them actually were born in Australia. And they say that they actually feel that they're affiliated with the culturally linguistic diverse communities. So this is what they identify themselves with. So Chinese, Indian, Greek, Italian, Maltese, and one actually identified herself as Australian, but she's caring for a Dutch partner. So they're caring for the parent, sibling, partner, or child. So these are the findings that we have found. 3 main themes. So the first one is cultural barriers. Second one is service inadequacy. The last one is care, self-care, and well-being. So in each of these main themes, there are 3 to 4 sub-themes. So let's look at cultural barriers. The first one is the poor understanding of mental illness. So many carers mention that, because of this poor understanding of mental illness in their own country where they're from, so therefore they feel actually quite isolated. They feel they couldn't get support from their own family members. So for example, from this quote, it says, because in my old age, because of my generation back in China, we didn't have any mental health education. So therefore, I can't talk to my family members. I can't talk to them. So oftentimes, because of this poor understanding of mental illness, carers from culturally linguistic diverse feel that they have little support from their own family. The second point regarding cultural barriers is stigma of mental illness. Again, this is quite commonly known to a lot of people. There's often quite a lot of stigma about mental illness. For example, it's about black magic or poor psychological health, poor mind power. So because of all this stigma of mental illness, so this stigma causes carers to be isolated even from their own family members. The third one, which is what Ash has mentioned, there's limited English language. For example, this quote over here, this carer was born in China. So my husband is Aussie, but he's the main one that's looking after boys. And because of my language problem, I haven't found any support group for the Chinese. So this language problem were often quite challenging for carers, especially those who were born overseas and those who are caring for aging parents. So for those who are caring for aging parents, these carers, they are often born in Australia, but because their parents came from another country and now they are pretty old and they need a lot of healthcare services, GP appointments, but the parents were able to converse but not able to talk to the healthcare practitioners about those health concerns. So therefore, carers have to often interpret for them, have to manage services to support their parents. So next, I move on to service inadequacy. So carers mentioned of this lack of family inclusive approach in mental health services. So as you heard in a previous presentation, most of the time, family members, carers, they're not involved in a discussion. And oftentimes, even when they're involved in a discussion, the conversation actually were quite basic. Oftentimes we heard from carers say that they will be in the room, but they were not allowed to communicate. They were not allowed to give their opinion. They were not allowed to be part of a discussion about the mental health treatment plan. So services should be more family inclusive to acknowledge the importance of families in the culturally linguistic diverse communities. The second point is an unsympathetic attitude from some professionals. So carers mentioned that, even when they are part of the discussion with the service providers, they were given information, but oftentimes they face quite a number of mental health professionals who are not sympathetic, who are not caring, who are just basically doing their work, but not really showing true empathy with them. So therefore, it causes them to feel that they are not connected, they feel they're not getting the necessary service. And carers often say that they need to be looked after by mental health workers as well, to check in with them, ask how well they are doing, ask them whether they require any other support. as mentioned by this person in this quote over here. The next sub-point in service inadequacy is poor support services and time-limited caregiving help. So although carers might be receiving services, often these services to them is inferior quality. Workers is not responding to them, or oftentimes all these services there's a time-limited basis, and after a while, they are being cut off from the service. They don't get any more support, as what this carer mentioned regarding carer gateway. Services seems to be temporarily, and they require ongoing support from organizations. So these inadequate services added further negative impact on carers' well-being. Next, I move on to the main thing that we look at in this study, which is about carer self-care and well-being. We really want to find out how do we support carers' well-being? How do we help them in terms of recovery? And also, is there really such thing as carers' recovery? So these are the few things that we have found. The first one is the stress of caregiving contributing to the neglect of their own well-being. As many carers will know, oftentimes caregiving can be quite challenging, and oftentimes they neglect their own physical health, they neglect their own social relationship. So because of all this, the stress of caregiving oftentimes lead to them neglecting their own well-being. And carers reported stress, worry, anxiety, especially in the early part of the care recipient's mental illness, which resulted in carers having difficulty taking care of their own health and well-being. The second sub-theme is the importance of self-care and useful strategies. So we asked them what are the things that will be helpful for you, to help you maintain good well-being. So they mentioned quite a number of things. The first one is regarding personal activities such as going for yoga classes, cooking, reading, spending time alone, listening to music. The second important part is social activities. For example, going out with friends, volunteering, helping out in some kind of organization, and even having some kind of respite so that they can have a short trip with friends, short holiday with friends. The next thing that they mentioned is physical exercise like swimming, netball, walking, tennis, and cycling. Of course, all of us know physical exercise is so important, but oftentimes this is the thing that's being neglected when we are busy, we are stressed with too many things. The next thing that we ask these carers, they mention religious and spiritual activities. So it could be reading scriptures, it could be meditation, it could be joining some kind of choir, sing spiritual songs together. So I think this is quite important because we are talking about culturally linguistic diverse communities. And oftentimes in mental health services, we often tend to avoid talking about spiritual things, so religious things with caregivers, but to them, this is really important. And the last point regarding self-care and well-being is the limitation of support groups and therapy for carers' well-being. I'm a trained social worker, so we often advocate for support groups, we often advocate for counseling for people. But according to these carers, all these counseling, psychotherapy, all these things is important, but oftentimes it is limited. It can't really solve all the problems. And oftentimes it requires a lot of physical help, practical support to them. The second thing that they mentioned is regarding support groups. They say that support groups are good, but oftentimes it is limited because of language. So not all languages are available in support groups. And even if it is available, oftentimes they're found in the Western Sydney suburbs. For example, someone living in the eastern suburb, they require a certain language group, but they can't travel all the way to Western Sydney to attend that support group. So the other thing regarding self-care well-being is a recovery concept. So we asked them about recovery. What do you think is recovery? How relevant is recovery? So these carers that we interviewed, they were all part of some network of carers organization. So they do have pretty good understanding of what is recovery. So they say that, yes, we agree about this concept of recovery. We think that it is important, but the word recovery doesn't go well with them. They feel that recovery this way is often for patients with some kind of health issue. So they say that other terms will be more useful. For example, good self-care, well-being, respite, maintaining wellness, recharge, recovery, timeout, and to feel healthy. So I think that, the next part of the research is really to unpack, what is this cultural concept of recovery? How do we really help carers, to maintain wellness, maintain good self-care and well-being? So for implication, the first one is family inclusive approaches. So there are family inclusive approaches around, but oftentimes they are not routine care. And oftentimes a lot of family members feel that they are quite neglected. And for second one will be, we still need support groups. And most carers who attend the support groups find it's really useful. They help them to connect with other carers. They help them to share stories, help them get strategies, how to cope. But often, I think the challenges will be, whether it is available to them in terms of timing, in terms of the mode of being delivery, and also whether it is available, they're able to travel to their particular location. The third is how do we promote self-care, how to promote well-being in carers. And the last one is come up with some kind of culturally appropriate recovery concept that is suitable for carers. So these are some kind of strategies that I think based on the CHIME framework that how we can support carers. First one is supporting the recovery of people experiencing mental illness. Site rehab, it is important. How do we provide interventions to support people to recover? Without interventions, it's hard for people to recover. The second one will be having a recovery-oriented mental health services. We have talked about this in mental health services for a long time, but do we still operate with a medical model? Do we still operate with a basis that we try to treat symptoms only? Or are we talking about recovery for people? It's a unique journey. The second one is how do we support carers in their caregiving responsibility? We need to provide them with information, skills, resources. How do we include them in the treatment discussion? How do we consider their culture in practice? The last one is how do we help services to support the recovery of carers? Helping carers to be aware, there's such thing as recovery, there's such thing as good well-being. We need to think of good biopsychosocial wellness assessment, think of good peer support, community support, think of a range of services to support carers. So I think that the support for carers will be based on something like this, a framework where all carers, in terms of information for illness, information for medication, information for resources, that should be made available for all carers as a routine practice. Then we need to think of how do we involve carers in a family inclusive practice in mental health services, how do we involve them in discussion about treatment, care, and so on. Then we need to have support groups. We need to have community groups to support them. Then we need to have more specialized family psychoeducation program, of course, specialized family therapy. So moving forward, we need to think about recovery. We need to think about family inclusive approach, and also think about culture. How do we support the culture of carers? So with that, thank you. I'll pass this time back to Lukas.
Thank you, Abner. And again, thank you, Ash, for your insights. That were two very insightful presentations on examples, on very specific contexts, on supporting carers from culturally and linguistically diverse backgrounds in the context of cancer and in the context of mental health. I felt there was a large overlap in sort of the identified needs and the identified gaps in the system. And unsurprisingly, from a carer point of view, they relate to information, they relate to identification, they relate to system navigation, they relate to the need for respite, and they relate to the fact that all of these needs to be provided and supported in a specific cultural context of the carers. So we're all back together on screen for a bit of a panel discussion, which sort of in the light of these very specific examples that we heard from you, I would like to start off with the question, sort of, when thinking and centering the group of culturally and linguistically diverse carers, what really is the biggest gap in the evidence? What do we still not know that we should know and that needs to be closed from your perspective? I'm pretty much open to the sequence in which we do it. I don't know, who would like to start us off? Maybe Reema? Yeah.
Want me to start? That's absolutely fine. Yeah, no, I mean, there's so much that could be said in this space, and I think really interesting presentations that I think probably highlight the gap in some ways. I think we often talk about the population being incredibly diverse and having a number of different, I guess, subpopulations within the population. Trying to understand what works beyond a small scale pilot with a very localized community is really challenging. The reason that we don't know what works is often because it's really hard to do. But, you know, having longitudinal studies that actually explicitly look at carers and have a sufficient degree of data that allows us to understand cultural diversity in a rich and meaningful way, and also explore intersectionality within that over large population cohorts in which carers and caring is included, is probably the avenue by which we can start to really understand what might work, and then trying to integrate that with the support that we want to build, I think is another step for us. So yeah, look, that for me is one of the big gaps, and I'll let others comment. I've got lots and lots more I could say there.
And yeah, this is something that has come up throughout this event before, and it is great to sort of add to it from sort of a CALD perspective. So the need not just for surveys, but also for actual administrative data collection that would allow for longitudinal studies and that would allow for large-scale studies, and the challenge to integrate intersectional data there, which I think is really a big administrative challenge as well. Abner, would you like to add to that?
Yeah, I totally agree with you, Lukas and Reema. You know, in terms of what we know, most of the studies are really quite small scale. And because of the small scale nature, most studies are pretty much qualitative. So a lot of things we don't fully know. For example, in terms of the percentage of carers, you know, who are from culturally linguistic diverse, you know. So because we don't know, we don't have this kind of data, so it's hard to advocate. But we do know from the practice, in terms of practice, that we hear from practitioners all the time, you know, they do face a lot of challenges. How do we support people? But just that we don't have data to support that. But in terms of caregivers, oftentimes they mention one of the greatest barrier for them would be awareness of services. They feel that, you know, a lot of factors actually contributed to this awareness of services because of language barriers, because of their own knowledge of mental health issues, and other community factors, causing this awareness to be missing. So they find it quite hard to get services because they don't know. They just don't know about health, don't know about mental health, they don't know about where to get help. Yeah.
So the gap really being not just in sort of the evidence, but in actually the awareness and the information getting out there. From what we know and from sort of taking all that together, what would you say is the most, so Abner just mentioned one, the raising of awareness of what's out there, but what would you think is the most important aspect that services need to understand about carers from a CALD background, taking a more provider focused approach? We've mentioned quite a few things about cultural specific stigma, for instance, about culturally specific ways of information that need to be provided. What would you think is sort of the most important aspect that came out in your work that services really need to be aware of? It is a bit of this elevator pitch question. Yeah.
can add something there. So look, I think, because we keep talking about things like, obviously all the practical barriers to accessing services always come up in lots of research, and we talk about then engagement. But I think for the communities that we're talking about, and for staff thinking about how to do service provision, it's complex, because it's about trying to ensure that people feel safe and respected and understood and spoken to about services in language that's relevant to them, not just relevant to them in terms of your native language, but more about terminology and framing of service provision that actually lands with different cultural perspectives. And that's tricky, because service providers are often trying to meet the needs of a highly diverse population. So I think really trying to approach talking about services carefully and listening to the way that things are framed and presented in the cultures with whom they may work. Those are good starting points to try to think about how to make somebody feel like they can engage with the service and that they are actually going to be well supported there. So I think it's kind of not the concrete things always, it's actually the intangible, and that's what makes it tough, but not impossible.
It's the sort of the small gestures, the small ways of speaking that create recognition and that create awareness. Yeah, that's a good point. Anyone else want to chime in?
Maybe I just jump in. Yeah. So in current mental health context, client-centered approach is really important. Client come first. So, but we know that in a lot of diverse cultures, it is collective thinking. So how do we weave in this collective thinking into the current client-centered approach? I think that is a real challenge that a lot of workers face in mental health practice. So of course, Reema also mentioned something really important, which is the diversity, in multicultural communities. We can't assume that, all Chinese behave the same way, everyone from Vietnamese group think the same way. So we can't really do that. So, but yet we still need to think of this collective perspective in the current client-centered approach. How do we manage and weave in the two together? Yeah.
Right. Yeah, that is a tension. There's an interesting tension between sort of the individual focused style of service approach and sort of a more collective cultural background. Are there any examples, culturally responsive approaches that you've come across in your work that you would really say have worked and that really have had a positive impact, that you could maybe briefly describe what they did differently? Does any example come to mind?
I wonder if, and Ash, you might want to talk about, the things that we've thought about are, in relation to ICANN plan and the kind of that localization of the approach. Do you want to talk about that?
Thanks, Reema.
Yeah.
So we developed a program called ICANN Plan program, which is about engaging people from cultural and linguistic diversity in advanced care planning. So having those conversations around planning for future care throughout the course of the wellness or illness, basically. And the program was developed, co-designed with consumers from cultural and linguistic diverse backgrounds. And the emphasis of the background was to build partnership between interpreters and clinicians to how to conduct these difficult conversations, often sensitive conversations, in a culturally appropriate manner. And it was a really interesting process which we go through in relation to forming that program, having people from cultural and linguistic diverse background who have gone through the process of advanced care planning directly contributing to the development of the program. And some of the key elements which were identified, okay, how do we meet the expectations around the cultural expectations around of the consumers when doing these conversations. So like how should interpreters be present in the room, where they should be placed, where they should sit, how the eye contact, the physical environment of the room, how certain terminologies could be translated when there is no direct verbatim translation. So how to explain the concept of advanced care planning, for example, when it doesn't exist in a particular language. So having those conversations between clinicians and interpreters beforehand about certain elements that might need tweaking, that might need readjusting, which may work in certain population groups because there may be a direct translation, but may not work in certain population groups because that concept is missing in that population group. So how to explain that concept there then? So we developed this icon plan program. So it's like an education session for interpreters and clinicians, and then applying that education in practice through a feedback mechanism. And so currently we are piloting that program at a local health, at one health service, in terms of how to improve that engagement.
Thank you. It's a great example. Really, and then quite interesting that it didn't come up in the presentations, but it was the role of interpreters and sort of the role of how do concepts actually really translate. Thanks, Ash. Abner, can you think of a lighthouse example of
wouldn't say lighthouse example, but one very important approach in mental health would be even before we talk about culturally responsive approach, we need to think of what is a family inclusive approach. So how do we bring the family into the discussion? So there are some family consultation approaches, or even a single session family consultation approach that try to bring family at least for a beginning session to help family members to understand what are the concerns, where the service user is right now in terms of treatment. No, I think that's the first part. If we are not bringing family members into the discussion, how can we think about further about culturally responsive practice? Yeah, so that's my opinion on this. Yeah.
So it often seems to sort of, before the culture comes in, even the family and the carer needs to be recognized, and that's already a challenge. How would you say can workers and frontline staff improve that engagement then, especially sort of in the CALD context? What is steps, and what will be the changes? And that's probably sort of a bit of a opportunity for a final statement and final perspective. What are the steps that actually need to be taken to better support CALD carers, and what are changes that our service providers could implement now to have a very short-term positive effect on CALD carers? Can you think of sort of specific measures that would be ready to implement? I know that that is always the $1 million question: what can be done now? But yeah, Reema.
There's no single right answer to that, but certainly I think what we're seeing is this widespread recognition of the valuable role of navigation and all the different kinds of areas of service provision. And I think in this particular space, that idea of enduring funding for bicultural, bilingual or multilingual workers who are there not only to support people to navigate services for themselves, but who can also provide, I guess, taking some of the load off for carers in terms of that piece of work that they do, because essentially that's a big part of the role that carers play that could be taken away. That burden could be taken away by health system provision or reduced in some parts. So it feels like the evidence is at a point where, it seems like a logical step. The roles are currently piloting things and short-term things often, rather than really sustained efforts to really see what kind of impact those roles have. But it does appear to be the tangible next step in this space that would, I think, have a significant impact on carer well-being, as well as it would on other knock-on issues around access to care and care provision and appropriate services. So I think it applies in this space. And just, sorry, I'll add one more, is it's not, you know, not siloing carers so that there can't be people who need care. You know, so once you become a carer, you stop being allowed to be a patient or be somebody who needs care. And so how do we just frame it up that actually caring for a person means also caring for the people who are supporting that person around them?
Thank you. That is a very good formulation. And we might take that. Abner.
Yeah, there are so many things that in terms of mental health services could do. But I guess one starting point would be, how do we help mental health workers to be aware of their own culture background, of their own bias, and how they see other people from another culture. So oftentimes, because of their own bias or perspective, you know, they could sometimes think that, you know, everyone of the same culture behave the same way. You know, we take a very single perspective of a culture group, or sometimes could be some internal bias towards a particular culture. So I think first thing is to help workers understand that. Then after that, helping workers to understand more about other cultures. So of course, there are so many wonderful programs around, you know, to help us understand about different diverse cultures. So that would be the second thing, helping workers understand about other cultures. Yeah, then of course, oftentimes we hear in the media, we hear in some research papers about community awareness of health issue, especially for mental health. How do we help people to understand about mental health so that we can address the stigma in the wider community? So if people understand about the issues, about the symptoms, then people will be more open to talk about it. Then that will help mental workers to kind of address those issues a little bit better. But as what Reema mentioned, it is not just a single approach, it's really multiple approaches that we need to help support carers from culturally linguistic diverse communities. Yeah.
Thank you. This was an extremely insightful discussion. We haven't received any questions from the chat. This is kind of the last opportunity while I try to sum up sort of the journey that you took us on today. We had presentations about the experience of culturally and linguistically diverse carers in the cancer context and in the context of mental health. We discussed sort of one of the gaps in that space, both for evidence and for service provision, is small-scale projects, small-scale pilots that address issues locally, but there sort of seems to be a problem with scalability that has to do with the research data in the background, that there's a lack of longitudinal studies, and that there is really a need for longitudinal studies to include data that is intersectional in that respect, and that recognizes also the diversity within the diversity that we're talking about. Co-design was mentioned as one of the main positive aspects, of the main factors that could help overcome and improve supports for carers of culturally and linguistically diverse backgrounds, and a lot of sort of incremental change that is possible by being aware of the language that we're using, working with translators and interpreters in a way that is sort of really reflective of the varieties of cultures that we work in, that brings in families. But one of the big issues also that Reema mentioned, funding, scaling, and really bringing that the many good approaches that exist out there into practice. I would thank all of you for this great session. We haven't had any questions in the chat, so I think I would like to finish up now and thank you all for participating. It was a very intense second day. We had 3 great sessions. My thanks to you, Ash, Reema, and Abner, for providing us with so much insight. And I hope that I see everyone tomorrow morning when the Research Incubator Online Symposium goes into the final day. Thank you so much and see you tomorrow.
Thanks.